All right, welcome everyone to another installment of the Franciscan Missionaries of Our Lady Bioethics Lecture Series. My name is Dr. John Miner, and I am an Associate Professor of Theology here at the university. Delighted to have another installment here. This will be our 8th lecturer. All of them available on YouTube. Some of them, I lost a few on my computer or somewhere. Who knows where I lost them, but they didn't make it to YouTube, and I was pretty sad. The one about community health practice got lost, which was sad. So if you were there, it lives only in your memory. So the purpose of this lecture series is twofold. So first, it aims to increase the knowledge and awareness of bioethical issues among students, faculty, and medical professionals in South Louisiana. Second, it aims to approach these issues from within the Catholic tradition, kind of applying the perennial wisdom of the Catholic faith to the contingencies of today. If you'd like to keep up with the lecture series, feel free to type your email into the chat function and ask to be signed up. I'll sign you up. And keep an eye out for the fall. We have Dr. Charlie Camosi coming in the fall to give one lecture, a more general lecture on a throwaway culture in medicine and how we combat it, and giving the Friday morning lecture on a more detailed treatment of the moral status and use of animals in biomedical research. So this morning, I'm very happy to introduce Dr. Paul Scherz. By way of introduction, I'll tell you a bit about his accomplishments. So Dr. Paul Scherz is an associate professor of moral theology and ethics at the Catholic University of America, where his teaching and research focuses on bioethics. He's also the co-chair of the Catholic Clinical Ethics Joint MA program with the Pellegrino Center at Georgetown Medical School. Dr. Scherz's research interest draws on his dual trainings in theology and molecular biology. He received a PhD in genetics from Harvard and a Helen Hay Whitney postdoctoral fellowship to work at UCSF. After growing interest in the ethical and theological issues arising from his research, he received a PhD in moral theology from the University of Notre Dame. His research examines the interrelationship between theology, science, and medicine. And he has a couple of recent books. One, Science and Christian Ethics, which if you were here before, you heard us talking about a little bit. And second, he has an edited volume on aging called The Evening of Life. But he's also published on the ethics of end-of-life care, aging, transhumanism, AI, data ethics, and emerging genetic technologies. So how it'll work today for viewers, Dr. Scherz will present for 45 minutes to an hour, something like that. And then we'll have about 15 minutes for questions. So feel free to type your questions into the question box or the chat box at any point throughout the lecture. I'll collect them and present them to Dr. Scherz during the question period. So without further ado, Dr. Scherz.
Thank you for that introduction, and thank you all for being here today, joining in this for this discussion. So today I'm going to talk about population health. And population health has become a central framework in health policy, and it's easy to understand why. At its heart, this paradigm seeks to address the risk factors that lead to disease rather than the expensive acute care that follows upon disease. It makes sense to treat the root cause of a problem. In its simplest form, this means that rather than treating heart attacks, health systems should make sure that the risk factors of blood pressure and cholesterol levels are controlled throughout a patient population. At a deeper level, though, population health takes aim at the social causes of those physiological signs, the poor diet that leads to cardiovascular disease, or the social stresses that raise blood pressure. While this paradigm has circulated in health policy since the 1990s, it is only now that we are developing the informatics tools and reimbursement mechanisms to really put it into practice. In my talk today, I'm going to examine the ethical implications of these developments, taking the point of view of Catholic social teaching. After first defining what I mean by population health and showing how it in many ways is closely aligned with the Catholic moral tradition, I'm going to suggest that there are both good and bad ways to implement it by discussing two possible issues with this paradigm of population health. First, it may medicalize broader social problems, leading to improper responses to those problems. The second issue is the way that it threatens to engage the patient as a statistic rather than a person. I point to these concerns not to denounce population health, but to suggest ways in which it can be implemented in a more appropriate manner. First, though, let me define my terms in more detail. This is somewhat of a difficult task because people have used population health to refer to many different things. I think this is what happens when a buzzword becomes popular. People try to say that everything, whatever they're doing, is population health. But despite differences, all of these definitions tend to share two elements in their way of conceptualizing healthcare. First, the focus of healthcare is not on the individual patient herself, as in older models premised on the doctor-patient encounter. Instead, in these paradigms, the patient is understood as a member of a population. The collective of the population comes first in this mode of thought. Every population, be it a city, an economic class, a minority group, a health plan's patient pool, a hospital's clientele, or the nation as a whole, has certain health characteristics, a certain frequency of heart attacks, of cancer incidence, of mental illness, or a certain range of blood pressure or weight. The goal of population health is to shift the characteristics of the population, to decrease cancer rates, to shift the weight distribution lower. So that's what you see in this slide, where in the red would be the current weight distribution, but population health would aim to push it back through different mechanisms to the gray line, right? So a lower BMI amongst the population. It does this by addressing the risk factors and root causes of disease states that give the curve its shape. Doing so will not necessarily assist any individual patient, but it will change the shape of the population curve as a whole. Second, population health relies fundamentally on a probabilistic style of thought, using statistical data to implement change. One changes the relative frequencies of individual diseases in a population rather than curing individual disease in this model. Now, this goal can be accomplished in a number of different ways, and here I want to lay out three different paradigms, only the latter two of which I will discuss in depth in this talk. The first, as well as the most widely implemented one at a practical level in daily patient care, is the use of medications, or ideally, but more rarely, lifestyle interventions to address risk factors for poor health. These include things like adjusting diet, encouraging exercise, and interventions to stop smoking. But more commonly, they involve risk-reducing medications, statins for high cholesterol, blood pressure medications, metformin to address pre-diabetic conditions. These pharmacological interventions are clearly aimed probabilistically at a population rather than at the individual. The health system needs to treat dozens of patients with these drugs to prevent one heart attack or death. These medications have little chance of helping the individual patient herself. Health systems, insurers, medical groups, and government programs have developed detailed protocols and guidelines to direct patient care and prescription practices in ways that will best address population concerns, although they may not be the most appropriate intervention for any individual patient, given age, risks due to taking multiple medications that interact, or other factors. Now, I'm not going to address this aspect of population health in my talk today, although I am analyzing it in other projects. The second widespread mode of conceptualizing population health concerns the social determinants of health. This framework recognizes that health is influenced by social factors beyond the sphere of medical care. It's difficult to eat well and stave off obesity if one lives in a food desert. Homelessness and lack of stable housing leads to stress, exposure to disease, and poor diet. From a purely medical perspective, homelessness makes follow-up and ongoing care extremely difficult. On a similar note, lack of transit options through not having a car or the inaccessibility of public transit leads to patients missing appointments. More broadly, poverty itself is a health risk on many fronts. Racism causes health issues through unemployment and the resulting poverty in minority groups, but in itself also seems to have effects on birth weight. These broad social problems create risks to health and shape the incidence of disease across the population. Now, for many policymakers, it seems more efficient to address these upstream factors than wait to treat felt illness. Insurers and health systems are beginning to take this into account. Some are investing in affordable housing in their communities. Others are engaging with community food programs like urban gardens, cooperative grocery stores. Such projects make especially good sense as part of Catholic healthcare's community benefit programs, as well as its history. The sisters who built Catholic healthcare also looked to all of the other needs of society, founding orphanages, schools, and other institutions alongside hospitals. On a more individual level, poorer patients can frequently obtain transit vouchers. This model has been used for certain diseases like HIV in the wraparound care provided by the Ryan White program. But newer reimbursement mechanisms grounded in value-based care, capitated payment systems, and accountable care organizations are providing additional impetus to these programs. It makes financial sense to provide highest risk patients with housing, food baskets, and transit vouchers rather than pay for emergency room visits or hospitalizations. Trial rules for Medicare Advantage programs would allow these kinds of expanded supplemental health benefits aimed at improving population health goals for a wider pool of patients. These last points highlight different strategies that can be taken in regard to the social determinants of health. Either policymakers can address them at the level of society by reducing food deserts across the city, increasing affordable housing for all, targeting unemployment, or they can focus their energies on the highest risk, most expensive part of the population, providing only these possible patients with vouchers and housing. This is another way of addressing the population as a whole. Determine the outliers, the most extreme cases, and target only them for intervention. These would be patients most at risk due to combinations of social risks, especially complex medical conditions, as indicated by past failures to comply with medical care or those with greater numbers of hospitalizations. If health systems can identify these high-risk outliers, then they can target them with increased interventions, usually under the supervision of a care coordinator. The trick is to identify them early enough to provide the greatest savings. New data analytic tools, combined with the wealth of data available in electronic medical records, as well as other public data such as social media, are now making this task of identifying high-risk outliers feasible. And healthcare systems are investing in them through projects like developing algorithmic tools. So what should we make of these developments from an ethical and theological perspective? At first glance, they seem to be very much in line with Catholic social teaching. They have a broad focus on rights, not just the right to health care, but also the right to housing, the right to good nutrition. In short, the broad suite of rights that allow the individual to participate in society and contribute to the common good. In these ways, they affirm the human dignity of all of those made in the image of God. They also seem to accentuate the common good, at least in the broader focus on the social determinants of health, if perhaps not in the more targeted form. Such interventions seek to change social conditions in a way that will benefit all, thus contributing to the broader common good. At their best, such interventions could serve to deconstruct the structures of sin at the root of broader social evils like racism. Finally, such interventions demonstrate a preferential option for the poor. They recognize the extra risks run by those marginalized by society and provide them with extra care, targeted at their specific needs. There is thus much to appreciate in these frameworks from the perspective of Catholic moral theology. At the same time, deeper social, scientific, and theological analyses of these programs have raised some causes for concern. These concerns arise from the ways that these programs envision the individual in terms of a statistical population, as well as the ways that the interventions are organized. Catholic teaching is concerned not only with the aims of policies, but also the concrete details of their operations. Good intentions are not sufficient if the implementation is problematic. The rest of this talk will discuss these concerns. Again, my goal is not to denounce population health, since I think it is a very promising paradigm in many ways in line with Catholic social teaching, but to raise warning flags and suggest ways to mitigate possible dangers. The hope is that through the intervention of such analyses, these programs can be better designed and thus ultimately more effective. Okay, so what are these concerns? The first major reason for concern is that of medicalization. Medicalization refers to the process by which broader social and personal phenomena are redefined so that they become the purview of medical specialists. This can occur through a number of mechanisms. The first can be a simple matter of redefinition. A classic example of this includes how 19th and early 20th century psychology transformed homosexuality from a moral and pastoral concern over individual action into a disease category. And then this ultimately became tied to understandings of personal identity, moving out of medicalization. Another mechanism is the expansion of existing disease categories to cover a broader spectrum of behavior and personal characteristics, so that a disease eventually becomes a way to address a social problem. Many commentators have suggested that the category of attention deficit and hyperactivity disorder has been expanded beyond those patients with a clear clinical need for therapy to encompass many children who might be better dealt with in terms of shifts in the arrangement of contemporary schooling and classrooms. So for example, I think some states, I think it's Kentucky, 20% of middle school age boys have been diagnosed with ADHD, which seems that you're doing more than addressing those people with clear and important needs to be diagnosed and treated with this disorder. A last mechanism occurs when the ends of medicines are themselves expanded. Critics have long saw the goals of contemporary medicine as far too expansive, as evidenced by the statement of a right to health in the WHO's constitution, whose definition for health is a state of complete physical, mental, and social well-being, and with the right to health extending to the highest attainable standard of this complete state of well-being. While this may be laudable as a general social ideal, it becomes problematic as a practical statement of medicine's aims. As Ivan Illich argued so well, this model has given medicine the responsibility for the complete elimination of suffering. This goal is not practically possible because we are finite beings in a fallen world in which we are destined to die and inevitably to suffer from disabilities, ailments, and decline due to old age. Undertaking such a task will ultimately pervert medicine, either by, as Dan Callahan has argued, tying it to ever more expensive technological attempts to cheat death, or as Farr Curlin, Stanley Hauerwas, and many others have argued, by solving inevitable suffering, by eliminating the sufferer through assisted suicide, euthanasia, or eugenic abortion. On a more straightforward level, we know that the medicalization of pain as the fifth vital sign has been a complete disaster, contributing to the nearly 47,000 deaths in 2017 alone from the opioid crisis. And this has expanded over the last year, accelerating with the isolation due to the pandemic. Attempts at solving social and existential problems through the medical system can backfire in spectacular ways due to a failure to recognize the complex drivers of a problem. Medicalization thus can threaten to lead to many social, cultural, as well as medical problems. In the case of population health, medicalization can occur because the social determinants of health, which are in fact broad social and political problems, become redefined as health problems. Admittedly, many policymakers may see this as the only way to address them. In an individualist utilitarian society, too few citizens are concerned with broader issues of distributive justice, especially if it may cause inconvenience or expense to themselves. Everyone cares about health, though, especially if an intervention might serve to reduce the costs of healthcare, thus reducing their own premiums and taxes. Such a redefinition, though, inevitably brings social problems under the purview of medicine. We can see how this might be an issue in regard to population health by looking at two specific problems caused by medicalization. Such a shift both alters how a problem is addressed and ultimately shifts the ends that are sought through the interventions. Okay, so it changes how a problem is addressed and the ends that are sought to be addressed. Okay, so in the terms of ways problems are addressed, medicalization can shift who is thought capable of arranging a solution. Medicine requires an education in science, followed by a long apprenticeship in practice. It is both a science and an art, with an extremely high bar for entry in our society. Despite all of the movement toward patient autonomy, it is still recognized as a discipline requiring great expertise. No matter how much internet research the average patient does about his condition, he will still be at a disadvantage in relation to the doctor. When a problem becomes medicalized, though, the barrier of expertise necessary for engagement with it becomes similar to that found in medicine. It becomes an expert concern, requiring a background in research, policy, or economics, as well as long experience with an issue in order to gain entry into the conversation. Because of this, medicalization moves problems out of the domain of the public sphere. The problem is no longer something that lay people seem competent to address because they lack the requisite training and skills. Thus, the problem moves out of the sphere of politics and the public square and into the far more restricted circles of bureaucratic policy, or technocracy. It is removed from the hands of the local and placed into the hands of small circles of experts at higher levels of government and healthcare corporations. Now, let me say that it would be foolish to be reflexively anti-expertise, like so many in populist movements, since such a restriction to expertise makes sense in many fields, such as vaccination policy or epidemic response. However, it's more questionable in relation to the social determinants of health. By their very nature, these are problems that affect the whole of society. They are issues of wealth distribution, food policy, racism, transportation. These are fundamentally political problems. We frequently think of politics today in terms of division and conflict over political power, but I'm using the term here in the older Aristotelian or civic republican sense of matters of broad, shared concern that should be solved by engaging the citizenry as a whole in common discussion. These problems need to be addressed through such political engagement, as difficult as this may seem in our current political climate. If health policymakers bypass politics, then their interventions will face two possible reasons for failure. First, they will lack the requisite means to truly address the problem. Fundamental issues of social organization can only be addressed through solutions that have a broad social legitimacy, and this legitimacy can only be brought about through the political process. Otherwise, they can face widespread protests like the Yellow Vest movement in France, as pictured on this slide. It makes no difference if we develop effective vaccines to COVID if people refuse to get the shot. Well-developed plans of social distancing are useless if people shirk the rules. Furthermore, one might not be able to muster sufficient means. One sees this issue in contemporary responses to the social determinants of health. Instead of addressing the political economic problem of the high cost of housing in urban areas, a problem that will surely require a multifaceted response, medicalized responses, such as those frequently on offer, only target a few high-risk patients with housing vouchers, or perhaps a health system will help build a set of apartments. These are responses that, while good for some individuals, will not truly address the problem at hand. Moreover, such responses only address these issues after health problems have already developed and the patient has become high risk. But this approach defeats the whole purpose behind this focus on social determinants, which was to address risk factors at a broad level before problems occur. To take a different example, medicalization shifts the political question of how our food system should be organized to a technical question handled by targeted intervention. Numerous authors, like Michael Pollan, have traced the current problems of obesity to government policy. For example, subsidies for corn that lead to an artificially low price for high fructose corn syrup. Our agricultural policy has further enabled the centralization of farming into a few hands, concentrations of land that allows for industrial monocropping. Addressing such structural features of our food system requires extensive political engagement of the kind that a purely medical approach does not allow. Instead, medicalization may lead to a far more limited intervention, a few urban gardens, maybe a low-price cooperative grocery store, more likely some food vouchers. Medicalization, ironically, shifts the focus away from the need for structural reform that was at the heart of the social determinants of health approach into a much narrower range of technical solutions. From the perspective of Catholic social teaching, this shift to the expert realm is also suspect because it undermines subsidiarity. In the face of growing state power in the hands of fascist and communist regimes in the 1930s, Pope Pius XI, in his encyclical Quadragesimo Anno, declared that it is improper to centralize all social functions in the hands of the state and large bureaucracies. Instead, individuals, voluntary groups, and local authorities should be allowed to carry out those social functions and address those social problems that they can. This engagement is crucial for allowing people to participate in achieving the common good. Such participation is an important part of human flourishing. Subsuming social functions into expert bureaucracy undermines human flourishing through communal engagement. Of course, as Pope John the 23rd later clarified, this does not mean that there is no role for higher levels of government or policymakers. The federal and state government and various kinds of insurance bureaucracies must support and coordinate responses of local authorities and voluntary groups, as well as checking any injustice that may occur on these levels. The point is that a balance must be maintained. My concern is that by moving these issues into the medical and thus expert realm, generally also a realm coordinated according to data analytics, policymakers make it impossible for local agency and voluntary groups to participate. Moreover, subsidiarity has a practical justification as well. Expert analysis frequently works at an abstract, quantitative, generalized level. Such analyses, while valuable and revealing in their own right, can obscure specific problems of context and individual variation. Social scientists have repeatedly cautioned us about the way that the bureaucratic gaze can oversimplify problems. And one of the best books about this is James Scott's Seeing Like a State. These problems are going to be affected by the specificity of a context, and this must be taken into account. To take a simple example, the food crisis in Appalachia will take a different form than that in urban Chicago, and the solutions will also differ. The housing crisis in the urban tech hub of San Francisco will take a different shape than that in the small college town of Charlottesville. Subsidiarity, by engaging local organizations, enables local knowledge to be brought to bear on a problem. Someone might object that usually such programs addressing the social terms of health do use non-governmental and community organizations exactly in order to allow participation and engage local knowledges. This could solve these problems, but in practice, such NGOs are less free from expert control than they might seem. To function and act, they require grants from government or business. As much research on non-governmental organizations has shown, these organizations are forced to reshape their priorities and programs in order to align them with funding calls. An NGO will not get the grant if their programs do not meet the form prescribed by a request for proposals. These RFPs are themselves written in order to meet the best practices set forth by expert knowledge. Thus, the aim of engaging local knowledge and local participation is frequently defeated because local actors are subtly pressured to conform to the priorities of those with power and money, even when those in power have good intentions. Even beyond the issue of subsidiarity, there is the danger that a medicalized understanding of social problems will reshape the ends that we seek when attempting to address these problems. To illustrate this concern, let me take the example of loneliness as described by the sociologist Joseph Davis. Many people have noted that there is an expanding problem of loneliness in our society. I mean, this has only been made worse by the social isolation of the pandemic. The United Kingdom has even gone so far as to appoint a minister to take the lead on the loneliness problem. This loneliness epidemic has many causes: an aging society, family breakdown, individualism, and an increasing amount of time spent with technology. We intuitively recognize that loneliness is a problem, but what is interesting is the way experts have justified government attention to this problem. The health effects of loneliness. For example, loneliness leads to stress, which leads to inflammation and cardiovascular risk. Or loneliness is a risk for mental health issues like depression. The problem of loneliness has thus been medicalized. This medical focus then shapes potential solutions. For example, one set of researchers is working on a drug that can alleviate feelings of loneliness. Other solutions focus on forms of self-help or cognitive therapy that reinterprets one's situation in order to help one deal with the lack of intimate human relationships. Thus, the individual can continue in social isolation without experiencing the health risks of heart attacks and depression because they don't have the feelings of loneliness. Yet such a solution completely misunderstands the problem. Social isolation is a problem in itself because we are social relational creatures. It is not just the health effects, but the condition itself that is the problem. Even if loneliness had no health effects, social isolation would be bad because it is a failure to enact a basic human good. Similarly, homelessness is an evil not just because it leads to health risks, but because some in our society lack the basic human good of shelter, and because of what that reveals about our country economy, mental health care system, and the levels of despair and drug use in an area. Further afield, a problematic food system is bad not only because it leads to obesity and the associated health risks, but also, and perhaps more importantly, the effects it has on small farmers and the environment. As these examples suggest, understanding social issues in terms of health outcomes alone will almost inevitably reshape possible solutions. The solutions might aim to eliminate the threat to health caused by the issue, but may not address the fundamental problem itself. In so doing, medicalizing the social determinants of health may serve to undermine broader efforts to address the underlying human goods at stake by shifting policymakers' attention to health outcome metrics. Solutions might seek to optimize health or lower costs, losing sight of other important goods. It's not that cost savings are an improper goal, but as a primary focus, they can skew responses to health problems. For example, a recent article described problems with a common algorithm used by many health systems to sort patients into high-risk pools for greater levels of care. This algorithm predicted health cost rather than health condition, or this algorithm used predicted health costs rather than predicted health condition or health risk as the marker of interest. The researchers discovered that the use of this marker led to racial bias. So what the algorithm did was say, okay, who is predicted to have the highest health costs, and then focused on those patients. So this caused problems because Black populations have historically had fewer resources dedicated to their care. So they appear to have lower health costs for their health conditions. Because of this, Black patients with high health risks were more likely to be sorted out of the system for special attention. So they didn't receive specialized care. The algorithm did not see them as causing greater health costs because of the historical records that African Americans receive less health care. But these historical records results from the effects of structural racism on the health system. Thus, the historical experience of deprivation became embedded in bureaucratic tools aimed at cost savings. In these ways, human ends may not be met. My concern is that insurance companies and health systems might not be the best organizations to address problems like housing because their interests are obviously and appropriately narrower. Moreover, they should not have to address these problems in their totality. Just because an issue is medically relevant does not mean that it is the responsibility of the medical system. After all, we don't look to hospitals to provide a city with clean water and sanitation, even though these may play a far greater role in promoting health and extending lifespan than anything that interventional medicine may do. Does this mean that the medical system has no role to play? Of course not. The social determinants of health are indeed medically relevant, so healthcare should engage with other stakeholders to address these root causes. This should be done broadly, though, through the political system, not just narrowly through health experts, with health systems making their voices heard in larger policy discussions. A health system should engage local organizations, but not in ways that overshadow their ability for independent action. Action should focus on broad social goods rather than narrower metrics. These are harder things to do than might first appear. It would be second nature to address health metrics through forms of bureaucratic best practices. But these would be neither the most just nor the most effective ways to proceed. Catholic healthcare may be in an ideal position to engage other stakeholders since it exists in the broader ecosystem of Catholic organizations. It can more easily engage with Catholic charities, with dioceses or individual parishes, with St. Vincent de Paul groups, with organizations like Mercy House, or with Mercy Housing, or with Catholic worker groups. It can join forces in lobbying efforts. These organizations are much less likely to examine the problem from the point of view of health alone, thus preventing the problems of medicalization. So a moment ago, I mentioned one problem with algorithmic tools that sort patients: their tendency to recreate historical patterns of bias and discrimination in ways that seem more objective due to their quantitative nature. There are broader problems with algorithmic systems, though. Beyond attempts to shape the population as a whole through broad social interventions, policymakers can also shape the population curve by targeting outliers who are especially sick and use disproportionate amounts of health resources. right? So instead of focusing on changing the population as a whole, what they do will be to focus on the green circle area, this very high risk area in the population. Removing this long tail of health costs shapes the parameters of the population as a whole and reduces costs. In the past, the difficulty has always been identifying those individuals who were at increased risk. Now, however, we have big data. Experts in health informatics are hard at work mining the data available in electronic medical records, public records, on social media, and in the files of data conglomerators to get a better picture of potential patients' health risks. By training artificial intelligence on these data, they seek to give a prediction of future health, or at least the dangers to future health. Of course, as we saw, there are dangers of bias and inaccuracy with these tools, but they are extremely powerful. With these tools, health systems can identify the most complex patients, those with multiple comorbidities, those in complex living environments, those with difficult social situations, and target them for extra care. Frequently, this means assigning them a case coordinator who keeps track of them, helps them to manage and understand complex treatment regimens, and connects them to available social services. These programs hold much promise for providing targeted care to the most vulnerable, thereby possibly instantiating the preferential option for the poor, which is central to Catholic social teaching. Scholars frequently speak about the problem of social abandonment, but here the health system does not abandon those at risk, but pours more resources into their cases. That is not to say that there are no potential problems with this mode of engagement, though. While avoiding social abandonment, they may fall into another problematic mode of social engagement. The anthropologist Kevin Lewis O'Neill, studying regimes of addiction treatment in Guatemala, has drawn attention to the ways that people can feel almost as if they were hunted by current regimes of care. His case study is admittedly extreme, involving a Pentecostal organization that, at the request of families, tracks down addicts, breaks into their homes, wrestles them to the ground, and imprisons them in treatment facilities. Though extreme, he argues that this mode of engagement mirrors broader practices that occur in social services. After all, these population health interventions depend on identifying those most at risk, having care coordinators track them down and continue to follow them, and engaging in an ongoing regime of monitoring of their situation, and a regime of surveillance. The at-risk may thus become the quarry of population health. Now, at a surface level, this is all done for their own good, to provide services, rather than for an objectionable aim, such as exploitation or oppression. Yet receiving such care can have broader effects on life. Once a person enters into such a system, they enter into a broader network of surveillance. The intimate details of their personal, social, and family lives enter the glare of the health system, recorded in their charts. This, after all, is the point of data analytics tied to an individualized care team, to know more so that we can intervene more and earlier. It is not only the health system that knows more. Entering into the field of view of the health system, the patient at the same time comes under the scrutiny of other public agency, because part of the goal is to connect people to social services. Yet alongside social services, the patient becomes legible to the criminal justice, immigration, and child protective systems. Today, being known to one database frequently allows one to be known by all databases. More and more care workers observe one's personal life, meaning a greater chance of being reported for something. These are people struggling with chaotic lives, so there are bound to be failures of one sort or another that an observer might feel obligated to report. Many families enter into engagement with child protective services through healthcare. Sometimes this is clearly warranted, as in cases of abuse. But other situations of perceived neglect can be less clear. Anthropologists Stephen Timmermans and Mara Buchbinder have chronicled the difficult questions facing medical genetics staff dealing with families of children with metabolic disorders. These are disorders identified through newborn screening regimens. So these patients are receiving specialized care of how to deal with these children, but they have questions, the caregivers have questions as to whether they should report families for neglect when they struggle to adhere to complex dietary regimens, due to the difficulty of adhering to them, but also the cost of these regimens. In any case, it is not at all apparent that a child is better off in the foster care system than in a slightly problematic family of origin in many cases. Even if children are not removed, the family enters into a further cycle of continued observation, parenting classes, and bureaucratic administration. I fear that this pursuit of the poor and high risk can sometimes make their lives more complicated and stressful as side effects of surveillance. A preferential option for the poor can swiftly become a preferential demand on the poor that can be unwanted. One might suggest fixing the problem by merely attempting to remove all those possible legal entanglements in some way, even though it could be difficult. At a deeper level, one might ask if this model of pursuit is really all that problematic from a Christian perspective. After all, Jesus portrayed himself as seeking out the lost. He is the good shepherd who leaves the 99 to hunt down the one lost sheep. He is the woman who scours the house in the middle of the night to find one lost coin. The church is to go out to the highways to invite people to the wedding feast. As the Psalms teach, there is nowhere that we can hide from God. He is everywhere, knowing the secret intentions of our heart. If the church is to act as the hands of God in the world, seeking out sinners to call them to redemption, surely Catholic healthcare can use such tools to seek out those who are sick, at risk, and marginalized to show them God's love by offering them care. This is a strong argument for these tools. Perhaps, but there seems to be a fundamental difference between the pursuit by the church and the pursuit by population health. The church seeks to call people into a community, into a personal relationship with Jesus Christ, and through him to all those who make up the body of Christ, the church. At its best, Catholic healthcare serves as part of this apostolate, is part of the call to the fullness of life, eternal life. These data analytic tools, however, are not aimed and generally do not lead to such an engagement with the fullness of life. Instead, in the hands of many agencies, they are aimed at what philosopher Hannah Arendt and Giorgio Agamben have termed bare life, a bare biological existence. Bare life is a life that exists even in those denuded of community, an instantiation of the social isolation that many people feel today. Agencies aim to maintain biological life, but do not, because they cannot, aim at the richer form of life to which the church calls us. In such programs, human relationship may only occur under an official form. In this way, care through a modality focused on bare life can lead to even greater alienation. Let me provide an illustration of what I mean using the work of the anthropologist Lisa Stevenson. She has examined the relationship of the Canadian health system to the Inuit. Canadian social services should be, in theory, the envy of US population health practitioners. Already in the 1950s, the Canadian government sought to provide all of the goods and social services necessary to address the social determinants of health in the face of a massive tuberculosis epidemic among the Inuit. The Inuit were moved out of their cramped traditional housing that seemed to provide the ideal enclosed location for disease transmission and transferred into the modern housing seen here that was cleaner, more spacious, more hygienic. They were provided preventive healthcare, education, and other goods for which population health advocates campaign. Those who were sick were taken away to sanatoria. Unfortunately, as you might expect, these interventions undermined their older way of life and community, founded in migration between seasonal settlements and close interpersonal contact. Inuit life lost meaning and purpose as they lost their traditions. Even though such measures brought the immediate tuberculosis epidemic under control, they laid the foundations for an epidemic of suicides among Inuit youth that blossomed in the 1990s and continues today. In 2019, the suicide rate among the Inuit of Canada was 100 per 100,000 population. That's 10 times greater than the rest of Canada and 7 times greater than the US. When Stevenson was studying, it was even higher. So the Inuit lives had become medicalized with profound iatrogenic effects. Again, the Canadian government responded with a coordinated public health and social welfare intervention scheme, education campaigns against suicide, mental health services, suicide hotlines. These interventions did not work. In fact, Stevenson shows that they were experienced by the youth that they targeted in ways that led to even further alienation and isolation. They are alienating precisely because of their anonymous and bureaucratic nature aimed at a population. You might ask, how can they be anonymous if they are targeted? Some interventions at the population level will be anonymous by their very nature. The suicide hotline does not use names to decrease barriers to use due to fear or stigma. However, Inuit youth find the hotline less helpful than talking to friends precisely because they cannot be engaged as an individual. Even other more targeted interventions can be felt as anonymous though, because the person is seen less as a person and more as a number or statistic. The worker is interested in you not because of who you are, because of obligations of relationship. The worker was felt to engage the patient through the interpretive lens provided by the healthcare system. And the system was interested in the patient precisely because of the way that she impacts the statistical curve of the population. The individual was targeted precisely insofar as she contributes to certain population-wide metrics of disease or cost. Because the individual is only of interest as part of a population, she becomes interchangeable with others. Policymakers know that a certain amount of the time these interventions will fail. The statistics bear that out. Therefore, only some of the patients are expected to succeed, while others will fail and die. It does not matter to the policymakers exactly which patients succeed and which fail, insofar as the population curve is shifted overall. Now, this is at a theoretical level, of course. I mean, individual workers can be more engaged with the individual person, as I'll discuss later on. But the patients sense this broader theoretical framework and are offended by it. For Stevenson, this anonymity is symbolized by the identification numbers that were given to the Inuit on a disc that they could wear like military dog tags. This was back in this earlier kind of social services framework in the 1950s and 60s. This ID number, like a patient record number, was necessary to make the individual legible and trackable by the social service system, which couldn't record or keep track of Inuit names. Yet this led to the flattening of the person in the eyes of the system to only what was recorded in their file. This flattening and anonymization accentuates the problems felt by the Inuit and by socially marginalized patients in the US. One of the major social determinants of health leading to disease is the loss of community, a loss of people who know you by name and care about you by name. As Stevenson argues, the replacement of community by engagement through statistically mediated means of care is not merely inadequate, a statement with which I think most could agree, but it is also itself alienating. In her work, this alienation leads to failures to cooperate with a system that engages the person only as an interchangeable part of a population. While she discusses this in terms of Canadian public health and social services, it applies just as much to targeted population health services. Algorithms based in big data can only identify people based on a series of numerical markers. It knows them only as a bundle of risks. That is how the system engages these patients, as individuals belonging to a high-risk population whose risk needs to be managed and controlled. This anonymous knowledge of populations through number is not merely a policy, social, or philosophical problem. It is also a theological issue. Scripture is very concerned about attempts to number the population. When David completed a census without a direct command from God, God punished him by unleashing a plague on Israel. The census of Augustus that occurs at the time of Jesus' birth in Luke signals temporal imperial power in contrast to the kingship of Christ. Numbering signals possibly illegitimate power. Joseph Ratzinger, writing before he became Pope Benedict XVI, discussed the number of the beast in Revelation. He's, quote, "This beast, the power opposed to God, has no name but a number. It is a number and it makes men numbers. It obliterates men's faces. It obliterates their history. He is the function, nothing more," end quote. Here Ratzinger is thinking back to the experience of the Holocaust, but he sees these dangers as possibly more widespread given the growing power of information systems. Quote, "The machines that he himself has constructed now impose their law on him. He must be readable for the computer, and this can be achieved only when he is translated into numbers. Everything else in man becomes irrelevant," end quote. It is this elimination of all else aside from what is readable by bureaucratic systems that angers the Inuit. And it is this reduction to algorithmic analysis that should concern us. Like Stevenson, Ratzinger contrasts the number to the name. But God has a name, and God calls us by our name. He is a person, and he seeks the person. A name allows me to be addressed. A name denotes community, end quote. Jesus brings the personal God even closer by presenting him in a human form that can be addressed. Christ calls us each by name. He knows his sheep, and his sheep know him as persons. What this indicates is that the church and healthcare provided as part of the church's apostolate should seek true community, where each patient is known as a person. Now, this is not to say that such care coordination cannot be done in a good way, that it cannot transcend technical management to become a form of accompaniment, the accompaniment that Pope Francis has repeatedly called us to. Paul Farmer's organization, Partners in Health, seemed to have accomplished something close to this in its work in Haiti. And this is a picture of its hospital in Haiti. Its accompagnateurs, community members trained to be health workers, visited HIV patients on antiretroviral therapy every day as a part of a directly observed therapy program. They were there as a form of surveillance, as a way of making sure that the patients take their medications every day. Yet they also formed relationships with them, brought them food, had time to chat. They got to know them as individuals and could engage their questions and needs, in part because the accompagnateurs were already members of the community. So it is possible, but it's important to admit that technology can push against these kinds of forms of communal and personal engagement. Moreover, it is a difficult task to scale up. There is the danger that the care coordinator, who will probably be overworked, assigned too many cases, and emotionally drained, will in the end be able to offer only this false accompaniment, really through no fault of her own. Such programs are data-driven and will become only more so as they are rationalized over time. The patient may become known and dealt with as a member of the population. Yet what these patients need are communities in which they are known by name rather than by risk score. They need the social support of real relationships. This suggests that if healthcare systems are going to engage these kinds of targeted population health programs, they should act in close coordination with churches and other forms of local communities. Some programs are already attempting this. At the very least, care coordinators should be given a lot of time and a relatively low patient load so that they can engage with patients more closely. Okay. To conclude, population health brings important things to our attention, like the social determinants of health and the existence of high-risk individuals. Yet it also requires us to think carefully about how to address these issues. The most obvious way to go about things is to use analytic tools to address them through interventions by the healthcare system. As I hope I have made clear, this approach would be a mistake. It would improperly shift the ends sought and possibly be experienced by the targets of care as alienating and oppressive. Such a result would be self-defeating. Instead, these interventions should engage the political system, the community, and the church. Healthcare systems should serve as supports to solutions that ultimately must come from other sectors of society. Catholic healthcare is ideally situated to engage both politically and socially in this cooperative manner. It is only in this way that we can respect subsidiarity and participation, offering true accompaniment. In this way, each person can be engaged by name. So thank you very much for listening. Thank you to John Meinert for organizing this event. And I'd like to thank a number of institutions that have helped to fund my sabbatical, which was critical for me writing this. So thank you, and I'm happy to take questions.
Thanks again, Paul. So if anyone attending has any questions, feel free to type them into the chat box or the question and answer box. I'll give you a couple of minutes. Last night, it took people a bit to formulate questions, but then they started coming in. Maybe I'll start with a question I had, Paul. When you talked about a misuse of population health data, you often talked about it in terms of shifting ends. Could you be more explicit? Like, what ends should we be seeking, and what ends are we being? Is the use of population health implicitly pushing us toward that are inimical to what we should be seeking?
Right. So, in general, the idea about addressing the social determinants of health should be to address the underlying root causes, right? So, things like unemployment, lack of access to food, more generally, poverty, things like that. The use of population health, though, can shift us to more proximate ends. So, to the healthcare system, to things like, okay, just reducing costs or just managing certain aspects of the disease. The idea of using medication to eliminate the health effects of loneliness was that example, right?
Right.
You don't look at, okay, how do we reduce social isolation? You look at how do we reduce increased blood pressure due to loneliness, right? So it turns us away from what the original goal of this kind of paradigm was. Um, and the goal, I think, really that we should have as Catholic health worker to address Catholic healthcare to address the whole person to these more narrowly technical goals.
Mm-hmm. Could you speak a little bit to, because this goal we should be seeking, right? The alleviation of poverty and the service of the poor. How much is that? How much does that already evince a kind of medicalization that we're thinking about this in terms of healthcare systems instead of in terms of a broader church? So I tend to think about healthcare as being like situated toward the kind of immediate goal of health and therefore connecting to like these other things. But um, I don't know if you could speak to more like what's the specific goal of a healthcare or a doctor, and how would that relate to these broader goals of the service of the poor and alleviation of poverty and things like that?
Right. No, I think you're right that we need to think about it not just in terms of healthcare. And that's what I was trying to point to, that we need to think about it as a church as a whole and a society as a whole. I mean, I think there's two reasons to think about it, why this has become brought up for the healthcare system as a major problem. Now that we, aside from the COVID pandemic, largely we brought most of the kind of communicable diseases under control. A lot of our mortality and morbidity are due to not growth of non-communicable diseases, right? That's what a lot of clinicians are seeing. And that's what's driving up a lot of the cost of healthcare is dealing with these. So even coming from the clinic, if you're responding to the patient's needs, it makes sense to look at their wider frame of life and what do you need to do to, maybe you cannot individually address it, but how can you contribute to broader efforts to address these more fundamental issues? Now, the more practical reason for doing it is because, right, so this is a space where we are actually looking at these broader social problems. And health is one of the few things that we as a society can get around as broadly kind of accepted as a reason to intervene and develop social programs. It's hard to say poverty, alienation, social isolation should entail kind of this increased social engagement. I mean, it's not good that it's hard. It's bad that it's hard. Like, we should be concerned, but just practically, this seems to be something that people can get behind in a way that they don't get behind other kinds of intervention.
Yeah, and teaching students, most will still accept the category of health as something that can be true of each human, right? And so it can have a communal bearing, whereas a lot of other things no longer do. And so those are seen as matters for illicit intervention or something like that.
That's right. Yeah, no, I mean, I think that, people find it hard to justify it on kind of a more individualist model of our society as kind of leading to these interventions. But I think also, I mean, there's a way that the healthcare apostolate should be, in the Catholic Center, should be engaged with the church as a whole, right? That this is one aspect of it, and it should be engaging in these broader kinds of aspects. But because these social determinants do have a significant problem in health, there is a reason that healthcare systems do need to step in and engage.
Right. Have you seen any great examples of healthcare systems coordinating with local parishes, dioceses, Catholic charities in a way that um, makes this use of the social determinants of health much more oriented toward friendship or accompaniment?
Yes, I mean there are a lot of systems who are doing this in good ways, and I unfortunately did not write down the examples of the individual health systems, but I think there was something in Western Kentucky or Tennessee, but it's working through local parishes, right, and not parishes, but even like local regimes of the Black church to kind of find these high risk individuals and engage them in the social manner where it's not just the health system, but it's the health system in cooperation with their broader local community, right? So that gives a richer engagement.
Yeah, and I can see that avoiding one of the possible problems with what seems like a simulated friendship or a simulated accompaniment, where it's like, yes, you're here, you're learning about me, but you're still a caseworker, right? And I think people see that and they're like, look, the only reason you're here, I get it. And that could still hamper our seeking of the alleviation of poverty and health goals. Whereas if it becomes more engaged as local communities, um, those problems don't occur because the person's already embedded there.
That's right. And you build up relationships of trust. These relationships can be much longer term, and friendships do actually develop between the
Yeah,
workers and the patients that they're. So you don't have that distrust, you don't have that dropout, you don't have these broader problems of instrumentalization.
right. So Tammy has asked, we do have local initiatives through the mayor's office to combat health issues in the area. Kind of a very broad question. How do you propose that the different entities collaborate or coordinate? Given that I think almost all of us will accept that some kind of collaboration or coordination is necessary, um, I'm wondering if she's asking what kind of mechanisms are good for organizing that collaboration or coordination.
Yeah, I think that has to be done. Like most of these things, that has to be look at what are the different offices, what is different kind of situations on the ground in the local community, right? So if the mayor's office is doing these things, like having somebody be in contact with them or whatever kind of board that they've set up for that would be, so that you're in the conversation would be a good way to start. Having I think the community benefit programs for Catholic healthcare are good places to start building these good sources, to start building relationships um, with other kinds of charitable and non-governmental organizations to try to open conversations as to what can be done. I mean, in community benefit always should ideally do a review of what a community thinks that it needs. So a community needs assessment. And in that sense, you should seek out people in the local area. And from getting that sense of what people need, you can figure out what partnerships you can form and how do you do this in this broader way.
So here's another question from one of our students who's probably thinking about this right now in class. She's worried how much of the efforts toward the use of community health and a more kind of communal commitment toward health and flourishing will be resisted simply because our current healthcare system focuses so much on bodily autonomy, that it in some sense there will be a mismatch. And can you speak to that?
Oh, I mean, I think that's exactly right. We are focused on the individual body, on individual autonomy. And so, therefore, we have ignored these broader social questions, right? And I think that is, and what's great is we are seeing over the last 25 years, and now with the pandemic and the increase amongst the death rates among comorbidities and minority groups, we are seeing this increasing attention to how health is generated through our social conditions. Now, I think the student is exactly right that, and this was somewhat of what I was trying to get at, is that this goal, this better goal of looking at community and the social relationship to our health can be stymied when we look at it as it's the individual sick body, right, that we look at as high risk. And then we just try to affect kind of aspects of their health, aspects of their lifestyle, rather than addressing these broader social issues in collaboration with others. Right. So I think, yes, our focus on individuality, our individualistic kind of streak, our focus on autonomy alone really creates difficulties in this area. But theology, yeah. I mean, Catholic theology, the Catholic tradition has the resources to push back against that, right? Because we do see ourselves engaged in this common project, part of common good.
Yeah, without eliding legitimate senses of autonomy, right? Which is important, as we speak about with initiative and participation and stuff like that.
That's right. That's right.
Yeah, it's interesting too. I think a lot of people experience this focus on individual autonomy exclusively as part of the alienation, because it ends up treating people solely as bodies, solely as units, and not as embedded in these larger communities. And so, some sense our approach is in fact part of the problem.
No, that's right. I mean, this comes up a lot, even in clinical decision-making, end-of-life care, dealing with the patient as an individual, but rather than understanding the family system, which is a lot of what ethicists have to do, is that these people are embedded in families, which are kind of have their own culture, right?
Yeah. Yeah. Well, I don't see any more questions. So let me thank you again for speaking to us. I know I've learned a lot, and I'm sure other people who watch this video later and have participated have learned a lot. And so for all of you who attended, thank you. And thank you again to Dr. Scherz.
Thank you. Thank you for coming, and thank you for having me.